Thank you very much indeed for inviting me to speak at this meeting. So good evening, ladies and gentlemen. And as you just heard, I'm going to try and give a fairly rapid update on what I believe are the important changes in the new guidelines, both the European and the US guidelines. I'll focus mainly on pharmacological therapy because I think that's where most of the recent developments have been. So these are my disclosures. And this is an outline of what I want to talk about. So I'm first going to say something about the new phenotyping of patients with heart failure, or the subdividing of patients by heart failure according to left ventricular ejection fraction. And then I'll talk about the treatment of patients with different ejection fraction phenotypes. And finally, I want to say something about the treatment of patients admitted to hospital with worsening heart failure. So let's talk about the way that we currently phenotype our patients, and the new guidelines on both sides of the Atlantic mention 4 ejection fraction based phenotypes. One that we're very familiar with, heart failure with reduced ejection fraction, meaning an ejection fraction of 40% or less. Then these patients with an ejection fraction between 41 and 49%, patients who are now described as having heart failure and mildly reduced ejection fraction. This was previously mid-range ejection fraction. And then patients with an ejection fraction of 50% or above, now referred to as patients with heart failure and preserved ejection fraction. The 4th ejection fraction phenotype are these patients, patients with heart failure and improved ejection fraction. Previously, these patients were often described as patients with recovered ejection fraction. And these are patients who had an ejection fraction below 40%, but generally because of treatment have shown an improvement in their ejection fraction so that it increases above 40%. So now let's look at the treatment of these different groups of patients. And I'm going to start with patients with heart failure and reduced ejection fraction, the group of patients where we have made most progress over the past 3 decades. And the key addition to the new guidelines is, of course, the use of SGLT2 inhibitors, sodium glucose cotransporter 2 inhibitors, particularly empagliflozin and dapagliflozin. Now, why are these drugs in the new guidelines? Well, the reason they're in the ESC guidelines and the American guidelines as a treatment for patients with heart failure and reduced ejection fraction is because we have these 2 large randomized controlled trials in patients with HFrEF, both showing benefit of 2 different agents in this class. Not only that, but remarkably consistent benefit. Here you see the 25% relative risk reduction in this composite endpoint in both trials. Again, something that was seen in each of the 2 trials, this early separation of the Kaplan-Meier curve, so rapid onset of benefit. Not only this large relative risk reduction of 25%, but also a large absolute risk reduction with a number needed to treat, as you can see here in the DAPA-HF trial, of only 21 over the 18 months of therapy. So because we have these 2 trials, both showing this consistent benefit, both in fact, when added together, showing a reduction in cardiovascular death as well as heart failure hospitalization individually, both showing improvements in symptoms and quality of life, and both showing reduction in deterioration in kidney function. Because of those consistent and extensive benefits, SGLT2 inhibitors have been incorporated into the ESC guidelines with the highest possible level of recommendation, the strongest recommendation any treatment can get. They're in this table of the most important therapies with a class 1 level A recommendation. So a really remarkable story. It's only in 2019 that we published the DAPHF trial, and within 2 years, these drugs have got a class 1 level A recommendation. This is the corresponding text, and basically it says that we should be using these drugs in all of our patients with heart failure and reduced ejection fraction unless there's a contraindication or unless the treatments are not tolerated. And it's no surprise that the new US guidelines published earlier this year have an absolutely identical recommendation, the same highest level of recommendation, class 1 level A, and essentially the same wording. So very consistent recommendations on both sides of the Atlantic, and the American guidelines have the same table of these really crucial, what we now often describe as foundational therapies for patients with heart failure and reduced ejection fraction. The drugs that improve survival as well as reduce hospital admission. And there are 4 pills that we can give. There are 5 distinct treatments because, of course, sacubitril/valsartan is 2 drugs in 1 pill. And you know the previous 2 established treatments, beta blocker and MRA, and of course now an SGLT2 inhibitor. But what is almost as important in the new guidelines as the incorporation of SGLT2 inhibitors is a really fundamental change in the recommended approach to using therapy in patients with heart failure. And the 3 key changes in the new guidelines are summarized in this slide. So there's a great emphasis on speed. It really matters how quickly we start these treatments. We've been too slow in doing this in the past. The treatment of patients with heart failure is urgent, just like the treatment of cancer is urgent. These life-saving treatments need to be introduced as quickly as possible. The new guidelines prioritize initiation over up-titration of dose. So they say start all of these life-saving treatments as quickly as possible, even in a low dose. The up-titration to the target dose comes second. That is a big change from before. And maybe the most radical change from previously is that the new guidelines say that the old sequence, the old order in which these treatments were recommended is no longer required. There is no fixed sequence or order in which they should be used. There's no preference for starting any particular treatment over another treatment. And essentially, the guidelines say that we need to move away from this approach that was typical of the 2016 guidelines, this sort of stepwise approach, starting with the first treatment ever used in clinical trials, in other words, an ACE inhibitor, up titrating to the target dose, then adding a beta blocker, up titrating to the target dose, and so on and so forth. And the reason that we've moved away from doing this is that we realized that if we really continued to do this, then it could take perhaps as long as 6 months before a patient was switched to sacubitril/valsartan or received an SGLT2 inhibitor. So we were delaying the introduction of life-saving treatment unnecessarily. And we know that all of these treatments work very quickly. We know that they all work in different ways. Their mechanisms of action are distinct. Their benefits are additive, and therefore the goal is to implement as many of these treatments as quickly as possible. And the US guidelines are probably better than the European guidelines in how clearly they state this. They even go as far as suggesting that it may be possible to start some of these treatments simultaneously, in other words, together, or at least very shortly after one and another, and of course emphasizing the importance of initiating treatment before up titrating to the target dose. And then again, the US guidelines are very clear in stating that the order or sequence in which we use these drugs does not need to follow the historical sequence of clinical trials, so does not need to follow the chronology of the clinical trials. So this is the treatment algorithm from the American Heart Association guidelines, and I just put it up so that I don't forget to mention the important role of devices. They, of course, should be considered in people who do not have a substantial improvement in their ejection fraction with those foundational therapies. And then the guidelines also mention that there are additional medical therapies that we may consider in selected patients. And here you see those in the list to the right of the figure as you're looking at it. And there are two new entries here. One is potassium binders, which I'm not really going to talk about, and the other is a drug called vericiguat. And I'm going to say something about that and why it is in the new guidelines. And basically it is in the new guidelines because this was one of the other large positive trials in the past few years, the Victoria trial, using this agent vericiguat, which is a stimulator of this intracellular enzyme called soluble guanylate cyclase. This increases intracellular cyclic GMP, which is a number of downstream actions which should be beneficial in patients with heart failure. Now, the Victoria trial was quite different than the two trials I showed you with SGLT2 inhibitors or the Paradigm heart failure trial. Patients enrolled in Victoria were at much higher risk. They either were still in hospital or had been hospitalized within the recent past. And in addition to that, they had to have a very high natriuretic peptide level. So very high risk patients, very different than in the other trials that we've carried out. Here you see the same composite outcome I showed you for the two SGLT2 inhibitor trials, but this time instead of there being a 25% relative risk reduction, the relative risk reduction is only 10%. And unlike SGLT2 inhibitors, there was no reduction in cardiovascular death. This reduction in the composite endpoint was driven by a reduction in heart failure hospitalization. Now, this is not to mean that this treatment isn't valuable to have. Of course, it's great to have any effective therapy, and this indeed may be helpful in selected patients. But at the moment, in the two sets of new guidelines, vericiguat has a class 2B recommendation, so not as strong as SGLT2 inhibitors or sacubitril valsartan, and of course a level B rather than a level A recommendation because there's only one large trial. Now, there is a new study underway looking at patients more like those who were in the Paradigm heart failure and the SGLT2 inhibitor trials, so we will be getting more information about this treatment in the next few years. So what about the remainder of patients with heart failure? What about those people who have an ejection fraction above 40%, which, as I mentioned at the beginning of my presentation, really now includes three different heart failure phenotypes based on ejection fraction: mildly reduced, preserved, and improved ejection fraction. Let's look at the first two of those, and let's start with the ESC guidelines. Now, these guidelines, for the first time ever, do make recommendations for patients with mildly reduced ejection fraction. That's an ejection fraction between 41 and 49%. I'm not going to say much about this because Scott Solomon's going to talk a lot more about how we got to the recommendation for treating this group of patients. What's missing from the ESC guidelines is any mention of an SGLT2 inhibitor in patients with an ejection fraction above 40%, because the ESC guidelines were prepared before the results of the Emperor Preserved trial were presented. So this was the sister trial to Emperor Reduced, which I showed earlier. It was almost 6,000 patients in size and included patients with both mildly reduced and preserved ejection fraction, published last year in the New England Journal of Medicine. And of course, these patients were quite different than in the HEF-REF trials. So they were about 6 years of age on average older, and the 45% of patients in this trial were women compared to only 25% of female patients in the HEF-REF trials. There was a bit more comorbidity, and actually half of these patients had chronic kidney disease defined as an EGFR below 60 mils per minute. So a distinct patient population from what we've seen before. This was the primary outcome, so really the same as we've seen in the HEF-REF trials, this large 21% relative risk reduction translating into a large absolute risk reduction and very modest number needed to treat, this early separation of the Kaplan-Meier curves. Now, unlike HEF-REF, the primary endpoint was driven primarily by reduction in heart failure hospitalization. There was no significant reduction in cardiovascular death, but please remember cardiovascular death is much less frequent in patients with this heart failure phenotype. It's much harder to show a reduction in cardiovascular death, even in a trial this large. And perhaps almost as important was the safety profile, because that very good safety and tolerability that we've seen in the HEF-REF trials was reproduced in this trial in patients with an ejection fraction above 40%. All of these things that cardiologists get concerned about, ketoacidosis, amputations, very, very infrequent, and in fact not more common in the SGLT2 inhibitor group than in the placebo group. Even genital skin fungal infections, which are the most common adverse event, were actually pretty infrequent and really not that much more common in the SGLT2 inhibitor group than in the placebo group. So very good efficacy and excellent safety and tolerability. But because the US guidelines were published after the presentation and publication of Emperor Preserved, they have incorporated SGLT2 inhibitors. They get a class 2A, so that's quite a strong recommendation, a level B recommendation, because there's at the moment only one trial, and that's in both patients with heart failure and mildly reduced ejection fraction, as well as patients with heart failure and preserved ejection fraction. Now that's all going to change very shortly, because the sister trial to DAPI-HF, which is the delivered trial with over 6,000 patients, will be reporting at this year's European Society of Cardiology. So in about just under 4 weeks' time, Scott Solomon will be presenting this trial in Barcelona. We know from the press release that the trial is positive, but you'll get the full details very shortly at the ESC Congress. The new guidelines also mention something for the first time ever about patients with heart failure and improved ejection fraction. So people who had an ejection fraction below 40%, that's now increased, usually, as I said, with treatment. And the current recommendation in both sets of guidelines is not to withdraw treatment based on the TREAD-HF trial, which showed that a substantial proportion of patients relapsed if evidence-based treatment was stopped. So if your patient shows improvement in ejection fraction, do not withdraw treatment, because there's a very great risk that they will deteriorate again. So I'm going to finish by saying something about patients hospitalized with worsening heart failure. And although it's maybe not as obvious as I would have liked it to have been in the ESC guideline, there is a strong recommendation, so a class 1 recommendation, to try and start these evidence-based therapies in patients before they leave hospital. If they've been admitted to hospital with worsening heart failure, start all of those life-saving therapies that we have. It's a bit, I would say, clearer in the American guidelines. They also make this very strong recommendation. And the wording in the American guidelines, I think, is really good because they point out that hospital admission is a critical opportunity to start these treatments. We know that it's easier to do it when patients are under observation. We know that despite our best intentions, after people go home from hospital, often they get lost to follow-up, and our plan to introduce new therapies and to titrate therapies often don't get followed through. And we know that when a patient has been admitted to hospital with worsening heart failure, they are at extremely high subsequent risk of readmission and death. So when they're in hospital, that is a great opportunity for you to introduce these treatments that make a big difference. And we now have really good evidence that a lot of the treatments that we've been talking about can be safely and effectively started in hospital. These are the new positive trials that we've got in hospitalized patients. I haven't got time to go through these, but I do want to mention one of them, which provides more evidence for a treatment that I think is often forgotten about, and that's intravenous iron therapy. We know that many of our patients with heart failure are iron deficient. We know that oral iron does not adequately replace iron, and you have to give iron intravenously if you want to adequately replenish it. We know that by doing that, we can improve symptoms, quality of life, and functional capacity. But what we didn't know was whether treating iron deficiency might also reduce hospital admission and mortality. And recently we've got some new evidence that we can do one of those things. We can reduce hospital readmission, because in this trial in patients who'd been hospitalized with heart failure, over a 12-month follow-up period in around 1,100 patients, intravenous iron led to a clear reduction in heart failure hospitalization. There was no reduction in cardiovascular death, but this was not a very big trial. It had a short-term follow-up. It did not have many cardiovascular deaths. It was simply not powered to show a reduction in death, but there was clearly a reduction in heart failure hospitalization. So I would say more evidence that we should be screening for and treating iron deficiency if we get the chance. And both sets of guidelines, and I think for the first time in the American guidelines, there is a class 2A recommendation, again, quite a strong recommendation that we should be treating patients with intravenous iron. So this is my summary and conclusion slide. So it's been an amazing few years. We've got these two new pharmacological treatments for heart failure and reduced ejection fraction, SGLT2 inhibitors and vericiguat. We've seen the first ever recommendations for heart failure with mildly reduced ejection fraction. We've seen at least one trial so far that has suggested that finally we have a clear evidence for a treatment in patients with preserved ejection fraction. That's a SGLT2 inhibitor. We've also got more evidence, as I've just mentioned, for intravenous iron therapy. But please don't forget that the guidelines also make these very important new recommendations in the way that we use treatment, particularly this emphasis on speed and our changed thinking about the sequence that we use the drugs in. And for us, the challenge is making sure that our patients actually get these many life-saving disease-modifying treatments that we now have available. With that, I'd like to thank you very much indeed for listening.
Yeah.